Good morning, good afternoon, good evening, depending on where you are. Welcome to this webinar organized by KDIGO and the International Society of Nephrology. The topic of this webinar is Harmonizing Acute and Chronic Kidney Diseases, Definition and Classification. And this webinar addresses the lessons from a virtual KDIGO Consensus Conference that was organized in the second half of 2020. I'm Norbert Lameire and an Emeritus Professor of Medicine at the University of Ghent in Belgium, and it is my pleasure to moderate this webinar. I'm a co-founder of KDIGO together with Dr. Gary Aknoyan from Houston, Texas, and I'm also the co-chair of the KDIGO Clinical Practice Guideline Working Group on Acute Kidney Injury together with Dr. John Kellum from Pittsburgh. To remind us what the KDIGO proposal for AKD was, before the start of the Consensus Conference, I want to show you a few introductory slides. The 2012 KDIGO proposal for AKD, acute kidney disease, was the following. The KDIGO definitions for both AKI and CKD are based on alterations in kidney function and structure. AKI develops over hours to 7 days, and CKD is defined by an elevated creatinine or other evidence of kidney damage that is present for greater than 3 months. During the deliberations on the KDIGO AKI guideline back in 2012, the concept of acute kidney disease and disorders was introduced and proposed in the AKI guideline. The 2019 KDIGO Controversies Conference on Acute Kidney Injury, which was published in Kidney International in 2020 and actually was a preparation for an update of the AKI guidelines, recommends that a revised definition and classification of AKD should be better harmonized with both the definitions and classifications of AKI and CKD. This drawing shows you 3 different ovals showing the relationship between AKI, AKD, and CKD. As you can note, AKI is a subsegment of the AKD oval, but all 3 AKD, AKI, and CKD are linked and can evolve when things go badly into CKD. On the other hand, CKD is also a risk factor for developing AKD and/or AKI. Examples of acute kidney diseases and disorders that actually do not fulfill the criteria for AKI are listed on this slide. I'm not going to go in detail, but roughly they can be split up in 3 major diseases or syndromes. One's related to a decreased kidney perfusion, like volume depletion of congestive heart failure or hepatorenal syndrome. Parenchymal diseases, very well known to nephrologists, glomerulonephritis, nephrotic syndrome, pyelonephritis, interstitial nephritis, and so on. And then, of course, the post-renal or obstructive disorders, usually unilateral by stones or a tumor. These diseases are without or before a sufficient decline in GFR occurs to fulfill the criteria for AKI. Either the GFR decline is too small or is too slow. And any of these diseases can be superimposed on CKD. Some of these diseases, and that was lacking in the definition of AKI, but some of these diseases that we call now AKD are characterized by markers of kidney damage, like proteinuria, an abnormal urine sediment, abnormal imaging pictures, or kidney biopsy. And others, like, for example, volume depletion or congestive heart failure, are characterized only by a decreased GFR. A controversies conference that also was in preparation for preparing an update of the AKI guideline was published in KI in 2020. And they repeated that there is an urgent need on the exact criteria and indicators of severity of AKD, that the clinical importance of AKD needs to be further assessed, because between AKI, the 2012 publication of AKI, and until now, very little information on AKD was obtained, and the revised definition or classification of AKD should be harmonized with the definitions and classifications of AKI and CKD and should be tied to clinical management. This slide summarizes in more detail the KDIGO nomenclature for kidney function and disease. There are two major groups, the acute kidney diseases and the chronic kidney diseases. Acute kidney diseases are characterized by a disease duration of less than 3 months and are conceptually different from an initial recognition of CKD. And in the acute kidney diseases, we have to distinguish the AKI, acute kidney injury, which according to the KDIGO definition, which is very well known to the nephrologist and the intensivist, is, and where it is again stressed that it is a subcategory of AKD, and is defined by oliguria for longer than 6 hours, for a rise in serum creatinine by 0.3 milligram per deciliter in 48 hours in 2 days, or by a rise in serum creatinine by 50% or higher in 1 week. Chronic kidney, and then in AKD, or the KDIGO definition for AKD is of course the same one as AKI, if there is AKI. When there is no AKI, AKD is then defined by a GFR below 60 ml per minute per 1.73 square meter, or markers, the presence of markers of kidney damage for shorter than 3 months, or a decrease in GFR by 35% or more, or an increase in serum creatinine by 50%, all for shorter than 3 months. This is AKD. Chronic kidney disease has by definition a duration of longer than 3 months, and CKD by KDIGO is defined as the presence of a GFR below 60 ml per minute per 1.73 square meter, or by the presence of markers of kidney damage. Mostly of the time, most well known is albuminuria or proteinuria, but this time for longer than 3 months. So the KDIGO Virtual Consensus Conference on AKD was organized in the second half of 2020, between August 2020 to December 2020. The co-chairs of this consensus conference were the two co-chairs of the AKI guidelines, myself and John Kellum, and the past co-chairs of the CKD guideline, Professor Adeera Levin and Dr. Paul Stevens from the UK. The participants were international clinicians and researchers with experience or with having publications in the field of AKI, the field of AKD, and CKD. There were presentations, formal presentations. There was a long discussion, an extensive review of the available data, and 3 working groups were composed that then separately had other meetings, again, always virtually, and they were focused, one group on definition of AKD, another group on the management of AKD, and another group on the research agenda. A draft manuscript was prepared, has been many times reviewed and revised, and is virtually ready to be submitted for publication in the next coming weeks, presumably in Kidney International. So the objectives, to summarize then, of this consensus conference were revisit and refine the AKD definition and classification suggested in the 2012 AKI guideline, and describe the relationships between AKD, AKI, and CKD. Secondly, to develop, as far as possible, evidence-based management recommendations for AKD informed by epidemiology, and to identify the key areas of research required in this field with the aim to benefit clinical practice, research, and public health. And then also few original data analyses were presented using additional cohorts to the group to examine AKD epidemiology, together with a review of the literature to address the key conference questions. From now on, I have to introduce our speaker of this webinar. This is Dr. Adeera Levin. Adeera is very well known to the global nephrology community and really does not need a very long introduction. She is professor of medicine at the University of British Columbia, where she is head of the Division of Nephrology. Dr. Levin is executive director of the British Columbia Provincial Renal Agency and is consulting nephrologist at St. Paul's Hospital in Vancouver. Adeera was president of the ISN between 2015 and 2017. She is also the past co-chair of the KDIGO guideline on chronic kidney disease, together with Dr. Paul Stevens of the United Kingdom. Adeera, please, may I ask you to start your lecture? Thank you very much.
Thank you, Norbert, for that introduction and for setting the stage so nicely. For this audience, I think my job, or our job, because Norbert and I are going to answer questions together at the end, is to actually help this audience understand why we need to expand definitions and classifications and how important that is to improve patient outcomes. These are my disclosures and perspectives, and I think it's important to have these on the slide because I think as a clinician, researcher, and administrator, there's a real importance and need for clear definitions and classification for the various conditions that we all try to take care of. So what I'm going to do in the next 20 to 25 minutes, leaving a lot of time for questions, I hope, is give you the rationale that Norbert has, so Professor Lameire has very nicely set up for you, and then talk about the difference between definitions and classifications and how we use this to get to evidence-informed care. So I think this audience well knows that kidney disease is an important component of our lives, but in order to have public health strategies that promote kidney health, you need to have an awareness of the burden of disease. You have to define the problem and identify the causes and risk factors. Without that clarity, you can't develop and test interventions nor implement them, and you can't then actually improve the outcome of patients living with kidney diseases. And we also know that the future of nephrology is, and we've seen this in the last little while, to get a better understanding of the complexity of kidney diseases and look at multiple profiles, multiple environments, and at different time points. And that is relevant when we come to talk about AKI and AKD and CKD. We also know that there's an interaction of lifestyle, genes, and environments that's different around the world. And by understanding that, we will understand the diseases better. And importantly, within our current context, we are actually getting more and more data about biomarkers, genetics, the value of biopsies for diagnosis and prognosis, and probably even to help us address therapeutic targets. We have now novel study designs to test complex interventions and new therapeutic strategies, and this is leading to more clinical trials, more opportunities, and more targets. And I think that's really exciting for us in nephrology. And so if I look at the principles of models of care, is that you need to define kidney populations in a consistent manner. If you don't do that, you can't possibly then study it nor implement anything. And you have to consider development of care models that are specific to stages, severity, and unique conditions. And that's what we're going to come to in a moment, and recognize the complexity of that care and a need to integrate and specialize. So to improve patient outcomes, again, you need to identify the condition, have a better scientific understanding of the disease, effective evidence-based treatment strategies, and then knowledge dissemination and ongoing research. And that's the iterative process that we're all so excited about. And in the kidney space right now, there's a lot going on. So how do you define a disease? A disease is a particular abnormal condition that negatively affects the structure or function of all or part of an organism. And we are often known to be medical conditions. That's the definition of a disease. The classification of a disease is actually a modification of structure and function that affects the body from working normally. And so we know those are signs and symptoms, and diseases are classified into different types. And the reason I'm belaboring this is you might ask why we need a new term and why we need a new classification, or to add to our classifications and expand it. and I'm just giving you that rationale. We use lots of different kinds of classification systems. You know them for cancer, you know them for staging of CKD and AKI, and there are a number of them that are used, and I'm not going to belabor this, but they are based on different methods: physiological, pathological, epidemiological, and statistical. And any single disease can have a number of different classification systems, and often they are built upon over time as one gets more information. So, as Norbert very nicely said at the beginning, why we need to expand the definition and classification is so that we can actually help to take care of people who previously have not been captured because we didn't have a name for them. So we have to have all the abnormalities of structure or function over all time spans in all situations so that we can better study these people and then obviously improve their care. And just to make that point, currently, if you look at the definition of AKI, it occurs within 7 days, and the focus is on urine output and a rise in serum creatinine. And as Norbert pointed out already, you ignore all the other abnormalities like pyuria, hematuria, episodes of stone disease, obstruction, or acute GNs. They don't fit into that definition. So the term acute kidney disease expands that current classification so that we include all the abnormalities of structure and function in the less than 3-month category. And so we try and address functional and structural abnormalities and avoid the issue of severity, which is what AKI mostly concentrates on. Like all kidney diseases and disorders, cause remains an important element in order to improve our understanding. So we clarify the definition, improve the diagnostic accuracy, and at our virtual consensus meetings and conferences and discussions, we actually tried to clarify this definition and classification, improve the diagnostic accuracy, so that we could actually understand potential etiologies and try and guide clinicians and researchers as to what additional tests are needed, and then talked about general management, how to increase awareness, drug dosing selection, and how you initiate potentially disease-modifying drugs. And then we also talked about future research to help identify specific therapeutic options so that we can alter outcomes, because as you all recall, back when we first defined chronic kidney disease, we didn't have a lot of interventions or therapies, but now we actually have, because of clarity in defining the condition, we now have clinical trials and better understanding. I think that's very much the hope within the AKD space. So the definition of acute kidney diseases and disorders is any abnormality of structure or function of kidneys with a duration of less than 3 months. The AKI definition has very specific criteria, as I said, that are related specifically to creatinine and urine output and short duration. So AKD encompasses acute kidney injury, but it's inclusive of other events where the rise in creatinine isn't high enough or fast enough, or you don't know the urine output. And it also includes abnormalities of urine sediment, imaging, and acute GNs as examples. And many people have been talking about this for a while, but as usual, the Alberta group with their outstanding database of huge population actually wrote about this in April of 2019. And I'll just take you through kind of the importance of having this clear definition. So this is, Alberta is a large province in Canada. There's access to a large set of laboratory measurements in a universal healthcare system. And so in over 1 million patients, they were able to look at a cohort and have some very specific definitions of AKI, which was only by serum creatinine using conventional definitions. And in fact, here used an AKD definition very similar to what we're proposing, which is an index GFR of less than 60 and a preceding GFR of greater than 60, but that didn't meet an AKI criteria, or an index GFR that was less than 60 with no preceding eGFR and albuminuria, or a decrease in GFR of 35% in creatinine, increase of 50%, or new albuminuria. That was their AKD definition. And no kidney disease is index and prior GFR of greater than 60. And so this led to, firstly, a description of the percentage of adult residents who had CKD, AKD, and AKI, and any combination. And I draw your attention to the fact that over 3,000 people had AKD and over 1,000 people had AKI, and 10,000 people had CKD, which is pretty impressive. This is older data from 2008. And it's not so much the incidence of these particular presidents, but really what does that mean? So over time, over an 8-year period, the long-term outcomes of these various combinations are shown on this slide. And I think you can see my arrow, but you can see here that the number of people who actually developed CKD, who had AKD, is higher than those from AKI. And the various combinations obviously are worse in terms of mortality. But I think this very nicely and graphically demonstrates the importance of the clarity of the definition and the importance of the condition in terms of meaningful outcomes. People don't like dying and they don't like developing CKD. So those are two relatively important outcomes that I think you'll agree are vividly shown on this slide. So AKD was 2.5 times more common than AKI in patients without previous chronic kidney disease. Patients with this condition were older and had more comorbidities. And 77% of patients with acute kidney disease were detected in an outpatient setting. I think this is really important for us as clinicians, whether you're a nephrologist or a general practitioner or a cardiologist, that this is a very large group of people who aren't necessarily in hospital at the time of diagnosis. And as I said before, the patients with AKD had an increased risk of chronic kidney disease, kidney failure, and mortality. All studies have limitations. The results were all based on single creatinine values as the anchor and no knowledge of the clinical context. But the value of a large population-based database and this kind of definition is it really helps us to clarify the importance of this particular entity. So in all the deliberations of our consensus conference, we had a lot of conversations, and this is kind of a graphic that you will see in the paper that took a lot of energy. So first of all, as Norbert said, this assumes that AKI is always a part of AKD. People with and without kidney disease can develop AKD or AKI, and there are a number of functional outcomes that occur. You can either resolve and go to normal kidney function and normal functional reserve. You can have normal kidney function and reduced functional reserve, and that's important because that's a concept that in nephrology we have not spent a lot of time on. Many of you will know that in cardiology, you can have reduced ejection fraction, preserved ejection fraction. There are ways to do stress tests of the myocardium. We haven't formalized that in nephrology, but there are some nice studies that demonstrate that after an episode of AKI or AKD, you may in fact have less functional reserve, and that may well portend worse outcomes over time. You can also have the result of reduced kidney function, new kidney disease, or progression of your existing chronic kidney disease. And like all these names, causes always need to be identified, and that's something that we were very clear about during our meeting. So this is a table presentation of what Norbert showed you in words, and what I've been saying is that acute and chronic kidney diseases are terms describing abnormalities of structure or function. No kidney disease is something that we do need to be clear about. So it's a elevated GFR and no markers, but all the other diseases, so AKI is within 7 days, AKD encompasses AKI and is in less than or equal to 3 months. And it's written here, and I won't belabor it because you've heard both Norbert and I say this a few times now. The most important thing that helps us with this AKD is the markers of kidney damage, albuminuria, hematuria, or pyuria. And I think that's quite important. And in the conversation around staging, there was a lot of discussion around how one might use albuminuria for AKD staging as we do in CKD staging, but that's not quite ready for prime time yet. What else we did at the consensus conference is really say, you know, we've come a long way and now we have a good name and now we have a good understanding of the construct, but we still need to do a lot of research. And so this is a table from the paper that describes the key research questions into 3 big buckets: identifying causes and risk factors, right? So as I said at the beginning, if you can improve the identification and risk stratification, that will be really important. So can we consistently identify who's at risk for AKD when you define it by different parameters, different severity and timing or duration relative to AKI? Can we identify patients who are more likely to have AKI instead of AKD despite similar exposures, like not that large rise, no change in urine output, so lesser forms, if you will, of kidney injury? And whether or not albuminuria categories convey the same impact in acute kidney disease that they do in chronic kidney disease remains to be seen. Now, one can argue that the pathophysiology is likely the same. It's not clear what the stability is and what if it has the same implications in terms of independence as it does in CKD. And we don't know how much albuminuria might change during acute kidney diseases. I think very importantly for many people is what the value proposition for patients in the healthcare system is to identify AKD. It's the sort of so what, and that's what we used to say at the beginning of CKD, some of us will remember, so what? So you define something. So the so what is, if you have acute kidney disease, might you look at drugs and exposures differently? Might you look at preservation of kidney function differently? So I think these are things, might you initiate other therapies differently than if you didn't do it? So we really do need to help socialize this whole notion of the value proposition. And then optimizing diagnosis and evaluation is also important. How do you improve the precision of the diagnosis and workup across all communities and health systems? So we come from lower middle income and high income countries, and what are the resources available to people? What is a minimum diagnostic workup for those who are discovered to have acute kidney disease? And when is a kidney biopsy of value? As many of you will know, there's currently a kidney precision medicine program in the US looking at biopsying AKI and AKD as well as CKD to try and understand whether or not there are situations in which biopsies are helpful diagnostically. And can we develop more sophisticated tools to look at the clinical state and degree of functional reserve? And I spoke about this earlier. I think we in nephrology have been a little bit behind the times in figuring out practical ways to do stress tests, for example, for kidneys. There has been variable interest in that, but we haven't sort of formalized it. The cardiologists and others have done such tests. Pulmonologists and cardiologists know how to test for functional reserve. We probably need to think about how we might do that and how that might help to further classify. And then, of course, the bucket of developing and testing interventions. What's the appropriate follow-up? There are many who advocate for AKI or maybe AKD clinics when people are discharged from hospital or discovered. And what would that look like depending on the severity, the duration, the context, and the resources of your particular healthcare system? What's the minimum clinical surveillance? What's the optimal time to reintroduce medicines that you've held, like the ACE inhibitors or the ARBs or the SGLT2s once you've had an injury? Are there interventions that mitigate, prevent, or delay consequences of AKD? And do we know that the treatment strategies that we have for albuminuria should be the same in AKD as in CKD? And of course, you know, in the world of clinical trials, we have to think about novel study designs to help us accelerate our understanding and testing of some of these interventions. And obviously, the underpinning of all of this is we really do need to improve our mechanistic understanding of acute kidney disease, probably in the context of AKI and CKD, but the more we understand from a mechanistic perspective, the greater is the probability of having targeted therapies and, for example, looking at molecular signatures, etc. So there are so many questions to ask and answer, but I'll remind this audience that 20 years ago, we came up with CKD, and look how far we've come by actually defining, socializing, and continuing to use the concept of CKD to drive clinical research, clinical care, and discovery of new and therapeutic interventions. So if we consistently identify acute kidney disease and seek the cause, we will learn more, be able to potentially identify therapeutic strategies, design clinical trials to test those strategies. And in the short term, which is what we can do right now, we can facilitate patient management by avoiding certain medications, increasing the awareness of risks, and time therapeutic interventions appropriately, so that we actually do the best we can with the knowledge that we have in the moment whilst we build our knowledge base. So we need to tip the balance, and better nomenclature actually leads to better care. It's not just another word, AKD. It actually helps us to conceive of that space that previously was undefined, and so that we can generate this evidence base and inform care whilst we acknowledge the diversity and continuum of disease and care. And so this is actually one of the figures that we have in the soon to be submitted paper that actually summarizes everything that Norbert and I have just said. That AKD incorporates AKI and fills the void between AKI and CKD that has existed. That it's more prevalent than AKI, that it incorporates markers of kidney damage, it's under-recognized and is associated with poor patient outcomes. And by recognizing and having appropriate management, we might improve patient outcomes. And that is what we're trying to do within the context of the role of KDIGO and ISN in trying to fill this space. So with that, I'll remind you that this talk was on harmonizing acute and chronic kidney disease definitions. And both Norbert and I are happy to ask and answer questions. And I think you should use, people should be using the question function in the webinar, right?
Thank you very much, Adeera, for this brilliant thing. As Adeera said, we welcome questions from the audience, and please type your questions in the question box. Dr. Levin graciously agreed that she should take only the difficult questions on, while I am excused because of age, probably, I take only the easy ones. Now, while I keep an eye on the question box to see when the first question will appear, I could probably start by a question that intrigues me a little bit since the Consensus Conference. Adeera, you pointed out a very nice Alberta study, and just to remind you that 3/4 of the cases of AKD that he diagnosed was in the ambulatory setting, was in the general population. Now, the authors, Matt James and others of that paper, had the good fortune that they had a creatinine available. Of course, we don't have that in the general population. So I asked myself, we badly need to know the epidemiology, the incidence and prevalence of AKD. How if we do not have routine creatinine measurements in a population outside the hospital, so in people who never have had access to medical care, how will we ever be possible to determine the epidemiology of this disease? Is that difficult enough for you?
That's very difficult. So the answer is we won't know, right? We won't know until they get sick enough or come in. So if you don't have, and in Alberta, it's not that it's whoever had a creatinine. So that's another limitation. If you never had a creatinine, then you couldn't have been counted in the population. I think the critical thing about this AKD is that we don't know the prevalence in all communities in the absence of knowing the serum creatinine, obviously, at the current time. I think it's fair to say that many people arrive at a doctor's office or a health unit or a hospital with elevated kidney function, elevated creatinine or poor kidney function, and they don't have a preceding real episode of AKI, so they would be by definition an AKD. Sadly, the epidemiology will not be well known internationally. They will not be as easy to do until there are either point of care abilities to measure creatinine or other things. But I think we can probably extrapolate, given other things that we know, to look at that. So maybe our numbers for, just the same as our numbers for CKD, are also predicated on that knowledge, and we probably don't know as much as we should. And if you look at some of the Atlas stuff, CKD in some groups is 8%, but that's probably not because it's 8%, but because people don't measure creatinines. So sorry, it's a bit long-winded, but you're right, it's a hard question to answer.
Yeah, okay. So I see in the moment a number of questions appearing in the question box. For example, that's an easy one. Are there any research done on AKD, except the study, for example, that you mentioned in the JAMA of the Alberta study?
Yeah, so I think that we probably, in many studies that have been done that were looking at AKI, they may have really been also looking at AKD depending on the definition. But I think if the question is, do we have any study that's about intervention? Yeah, we don't know what the right thing to do is yet. I'm just trying to also open. I can't.
Do you see? You don't see this questions program.
I'm just trying to open them a little bit bigger, but I can't. You'll have to read them. Sorry.
But I can read them.
Okay.
I can read it.
Yeah. So I mean, there aren't a lot of studies. I think because we're just getting our arms around the definition and the clarity of that definition, and I think people can go back to some databases or some studies that have already been done, including clinical trials, and applying this definition. We can retrofit and now find out more about AKD using existing databases and previous studies.
Okay, so then down to earth question, is that so that we then every patient with hematuria or pyuria for 3 months, do we need to label that AKD?
According to our definition.
It should be, huh? Of course, yeah. Okay. Now, just coming back, and then I will go on for the other questions. Then a funny one is, can we say that AKD is CKD less than 3 months?
Yes. Well, no. I mean,
no.
No, because not all.
More difficult.
Not all AKD goes on, as I showed in that slide. It doesn't all go on to CKD, so it's not the opposite. It's an entity unto itself, with outcomes that are similar to, but not exactly the same as CKD. And I think that's really important.
That's right. But of course, what is in the progression of a CKD patient, probably there are intercurrent episodes of AKD or even AKI. Yes. And there's even theories that saying that, and we did such a small study in Ghent, but the steep of decline of GFR over the years in patients that were followed in our outpatient department, the steepness was more related to the number of intercurrent incidents of AKI or AKD than actually you would expect from a smooth decline in GFR. So the AKD, that is probably some of them goes undetected, is really very important. Also in the follow-up of a CKD patient.
Yeah, 100%. And actually, we have a similar paper with the BC data that actually shows that even when you return to baseline with your little blip in AKD patient, all those little bumps in creatinine that most of us don't pay attention to actually portend a worse outcome. And I think, you know, the transplanters know this well. They're always concerned about the little blips in creatinine. I think when you're taking care of chronic kidney disease patients, many people just ignore the little blip, but in fact, as you say, Norbert, like it actually portends badness. The trajectory changes. We don't yet know what to do about that. However, you know, we do know there are some drugs and other things that might reduce the incidence of AKD.
Yeah. Another one is if you have a patient with acute glomerular or nephrotic syndrome that is recently diagnosed or diagnosed for longer than 3 months and on treatment, how would you call that?
So when you
depending on the function, I think.
When you first diagnose them, they are acute kidney disease. That's what they are. Their etiology, just like we have etiologies for chronic, their etiology is GN, right?
Yes.
If they go on for longer than 3 months, they have chronic kidney disease, and the etiology is GN. So I think the classification system works well for that.
Yes, right. So then coming back, there just comes a question following up in my mind. Usually in clinical nephrology practice, if you diagnose glomerulonephritis, until after this webinar, everybody would say to in his letter to the GP, I just saw your patient suffering from acute glomerulonephritis. Would you now suggest that he says, I saw just a patient suffering from AKD based on acute glomerulonephritis? It will take a while before people are going to do that.
100%. It will take a while, just like it took a while to go from renal insufficiency and dialysis to CKD, and now no one knows there was ever anything other than CKD. So I think, yes, this person has AKD, due to acute GN.
Yes, okay. Then I think the question that is perhaps more addressed to myself is, say, to what extent or how often do patients with AKI recover within 7 days? With what is known so far, can one diagnose AKD straight away on evaluating a new patient with AKI, or should one wait 7 days? As AKI can also have hematuria, pyuria, etc. That's a tough one. I like that. Indeed, indeed, the definition of AKI, what you should not confuse in that question is, the definition of AKI says during the development of AKI takes a maximum of 7 days, depending on the increase in GFR, and the increase in creatinine, or the oliguria. Nobody, we discussed that a long time. You remember that, Adeera? Nobody knows actually what is the duration of an AKI. We all know 3/4 of the AKIs recover within 2 or 3 days. These are the easy ones. But many, 1/4 takes much longer to recover, if the patient survives, of course. And I'm now thinking on critically ill patients. So they take longer than 7 days. So they may recover completely, they may recover incompletely. And there is a tendency to say, forget about the 7 days, but there's a tendency to say, during this recovery phase, when the patient is no longer so very ill, when the creatinine is coming down again, but not normalizes, that episode we should call maybe acute kidney disease, because the AKI element is gone. We had a long discussion on that, and the people will see that in the paper. We explicitly said nobody knows what the exact duration of an AKI is, just to avoid the discussion at this moment.
Right, and the corollary is everybody with AKI, but de facto has AKD. The AKI is the severity, and if you have pyuria, that's not in the AKI definition. The only thing that's in AKI is rise of creatinine, that is a lot, and urine output. So anyone else, so everyone is AKD. If you have AKI, it's because you can clearly characterize the rise or the urine output. So I think, and the 7 days is as you said, Norbert, kind of an interesting concept. But if you remember the diagram that we showed, it's important to remember that AKI is inside AKD. So technically, everyone with AKI does have AKD.
That's for sure.
AKI because of the severity or the fact that you have no parameters other than creatinine and urine output.
Yeah. Another one coming from a
right? Because now everyone's used to saying AKI and not AKD.
Yeah.
So it take a while.
Another one coming from a well-known nephrologist, but I'm not going to mention his name. But how will you tackle the lack of biomarkers in low and middle income countries to identify structural damage in AKD or AKI? I think I may say, before Adeera responds to that, so far we have not found studies that explored biomarkers, and now I'm thinking albuminuria is also a biomarker, and urine sediment is also a biomarker. But I think the nephrologist thinks here on the more sophisticated biomarkers like NGAL and KIM1, etc. There are no studies, as far as I know, really correlating and judging the damage of the kidney in AKD patient. But while there are many, many studies in AKI. Now, his question saying, and that is also following by another one, in low and middle income countries where they do not have these biomarkers, how can I judge damage? Can you give a comment on that? I think albuminuria following AKI, which is people are now
Yeah, I think
Albuminuria is an important biomarker there. Huh?
Yeah, I think so. And I think it is, I mean, let's just use our COVID example. We know that post-COVID, independent of creatinine, there are people that have persistent albuminuria. And we know that that's a negative prognostic sign. There's a nice paper in Nature Medicine Reviews that has a nice summary of all of this.
Yeah.
I think, you know, in the absence of anything else, proteinuria is going to be our basic biomarker. Ideally, we'll have more and more sophistication as we go. It isn't a perfect biomarker, but I think it does say there's damage to the kidney.
Yeah. Then another one, very important one, coming from a pediatric nephrologist in Ghana, West Africa. I wanted to find out if these guidelines are applicable to children. We discussed children, right?
We did. I think there are some additional nuances with children because, but I think the answer is that that's part of the research agenda. I would think we do need to understand better, but this should apply because the concept would be the same.
Yes, yes, sure. And then another one, how to accurately estimate eGFR in AKI and AKD. Well, that's a good one. Actually, estimated eGFR in acute situations where I at first concentrate on AKI. This patient is absolutely not stable. So do not calculate an eGFR in an AKI patient. You simply cannot do that. You cannot even do a creatinine clearance in these, and particularly in critically ill patients. In AKD, where I think the patient is more stable, particularly when it is an outpatient coming into your nephrology department and you find an AKD diagnosis, why would you not estimate GFR in such a patient? In AKI, I think I would not do that because you can get all over the place. But in a stable, not very ill AKD patient, I don't see why you should not use an estimated GFR.
I think when we had the conversation in the various discussion groups, it was to find a period of stability of the creatinine.
Right.
When it is stable, then you calculate, quote, estimated GFR, because of all the points that you just mentioned. And then the other thing that brought up is that perhaps in this case, cystatin C might be better, but that of course doesn't apply to all locations. But it is important to think about, yes, I would agree, Norbert, like you can't do eGFR in AKI and you can't do it in AKD until you have a period of stability. And at that point, and that's when we also talked about the whole notion of functional reserve, right? And I think that that's something that we really do need to get better technology, simple and more sophisticated technologies for that.
Yes. Coming back to the GFR, as I said, also in AKI, where you have an estimated GFR or even a creatinine clearance, that patient is not stable enough to reliably calculate a GFR. But there is a new test which is very promising. That is the enkephalin determination in the serum that has been used already in critically ill patients and who have and even better than cystatin C, gives you a much more stable and much more reliable evaluation of kidney function correlated with the instantaneous GFR. So I think this may be a trick in the future that we can avoid the terrible problem in nephrology, and this is now between brackets, is that we are stuck with creatinine. Everybody, it's amusing to read all the papers on AKI. They said, this is the definition of AKI and on creatinine, and then to go on with a long complaint about all the disadvantages of creatinine. So we really need better evaluations of GFR.
The only specialty that always we always either overcalculate or excuse how bad our markers are, and I think it just behooves us to work a little bit harder to get the right markers or the right tests as opposed to just keep on defaulting.
Yes.
There is a really good question about what we should do with primary care physicians.
Right.
Whether the suspicion should be the same. I think it is about educating people that just because you don't meet the criteria for AKI, but you discover somebody with a lower GFR or abnormal sediment, that is a kidney disease of some sort, right?
Yeah.
Yeah, I think that's fair. But how we educate people without making it sound confusing, I think, is going to be a challenge.
It was already difficult to convince our GPs to follow the estimated GFR based on a creatinine. That took also several months, and they were fixed on the 60 ml per minute. And when the lab said it is 59, all these patients had arrived in the nephrology departments. So we still have a lot of teaching to do. I have a very interesting question from a colleague also out of a low-income country. I think it is Nigeria. They said they see a lot of children again with a fairly large proportion not fitting AKI and CKD. So he thinks, so his question is, what do we do with a patient with AKD? Can they be acutely ill? And how rapid must the GFR change to meet the criteria of AKD?
So it doesn't have to change to be AKD. It just has to be newly diagnosed. That's the nice, so you can put those people in that bucket and then you pay attention to them and you would do, again, this is not evidence-based, but ideally you would have increased surveillance. They might be sick, they might not be, right? And I think that was the whole point of having that bucket so that you didn't ignore them, right? But it's a great question.
Hopefully. I have two questions from a lady nephrologist I know very well, but of course, I'm not going to mention the name, but she's a very, very good pediatric nephrologist. Unilateral pyelonephritis with normal GFR, is this AKD? I would say yes, but Adeera, what do you say? Unilateral pyelonephritis,
well,
it's an AKD.
Unilateral pyelonephritis will have markers of kidney damage. They should have pyuria or albuminuria or hematuria of some sort. So in the absence of any of that, no, they don't have AKD, but I would bet that they would have to have one of those things for you to make that diagnosis.
Yes.
Remember that stone disease, we never knew before we studied it, that unilateral stone disease, recurrent stones, actually is a 10-fold increased risk of CKD compared to a non-stone forming population. And these people often have AKD, right? They will have transient urinary abnormalities, maybe a little blip in their creatinine, but again, they would be AKD.
Yeah. A tough one coming from a very famous nephrologist, Adeera, and not to scare you off.
I saw it.
You saw it. That's why I refer to you. Almost by definition, AKD is an unstable situation. This can influence the validity of the metrics used for its definition, such as the urine albumin creatinine ratio, due to instability of the denominator, urine creatinine excretion. Will this require unique metrics for each kidney disease category? That's a good one.
No, it's a great point, Dr.
Yes.
It really is, and I think that that's part of what people are wrestling with. I think there's a recognition that there's this space that needs a definition. Currently, the tools that we have are creatinine and albumin, and microscopy, and some imaging. We probably need to get better tools, and everyone recognizes the instability of those measurements, especially the urine ACR if creatinine is changing. But that's why there's been a bit of a reluctance to, in the absence of stability, to start to classify AKD because we recognize all of those nuances. But yeah, thank you for overtly calling those out.
Yes. Then a last one may be coming from Uganda. Knowing that the majority of AKD episodes occur at the community level, which is correct, thinking in terms of suspicion and training of primary care physicians, are the suspicion factors the same as for AKI, and is there evidence available for that? And in other words, should we be equally alert for AKD as for AKI?
Yeah, I mean,
I think so too.
Yeah, I think we should be, and I think probably the risk factors are very similar. Again, with better study, we may discover new ones, but I think yes. And I think it's also an argument perhaps for thinking about advocating for point-of-care testing, right? And inexpensive ways to test kidney function in different spaces and places.
Yes, okay. Thank you for the good topic. In sub-Saharan Africa, we have more malaria that can cause CKD, coming from a nephrologist from Guinea. I think that's correct. Malaria can cause not only acute kidney injury, but also certainly CKD. But I don't know what, in fact, the meaning of the question is, can it cause CKD malaria? I think sure. Any AKI can incompletely recover or no recover at all and cause CKD. And that would be the last question then, because we are at 2 minutes time. Adeera, you mentioned already COVID patients, right? We have, and you must have seen COVID patients with acute kidney injury, a lot of them, and they need dialysis for 1 month or 2 months. Right. The question is, would you call them, and they developed AKI, that's for sure. It's a little bit paradoxical that such a case, should we call them AKD, and on what time interval? Should you call that AKD and not an AKI that is prolonged for 1 or 2 months, needing dialysis?
So I think it's an AKD, right? Like, I think that's the definition of acute kidney disease. AKI is just about rise in creatinine and urine output. AKD.
Yeah, but that's the diagnosis. But nobody knows the exact duration of an AKI. Right?
No, but I think that this is by definition an AKD because AKI is a subset of AKD. I think if we start splitting hairs too much, we're going to get a circular argument. So AKI is a subset of AKD. Therefore, someone who's on dialysis for 2 months and comes off does have AKD.
Oh yeah, for sure. Yeah, sure. Yeah. Okay. Yeah. So I think we are coming to the end of this webinar. I think I found it amusing and very, very instructive, and I thank certainly the interest that there was. First of all, I want to remind you again, please watch out for KI in the next coming months, perhaps, because the paper summarizing this consensus conference and also this webinar will be published very shortly. I want to thank, in the first place, Adeera, you for your excellent contribution and for taking all these difficult questions. I also extend my thanks to the ISN and the KDIGO staff for their support in preparing this webinar and for the technical assistance. And finally, I also thank the audience. I hope you enjoyed this webinar as much as I did. And I wish you a nice morning or a nice afternoon or a nice evening, depending on where you are. And please stay healthy. Bye-bye, and thank you very much.